be a 17-year-old.
That's our patient.
Okay.
Face down, knees with it. Struck by a car.
So it's an autoped 17-year-old. Okay. Your assessment, obviously fractured leg, GCS of 3, obvious head trauma, also femur fracture, unstable pelvis. Those are the vital signs: 140 over 80, heart rate of 96, rest rate of 10, O2 sat of 94% on room air. Patient tolerates an oral airway. What do you do first? Okay, absolutely, absolutely, absolutely.
Right, in this person, you turn it over, a log roll, etc. But among these, what do you do first?
Yeah, immediately because he had breathing had a mid-90s stat.
This is to help prevent the GCS of 3 and a TBI. Put the tube in. This is exactly where all of us should be heading in terms of this type of thing.
So the first most immediate thing would be the supplemental oxygen, the non-rebreather.
And honestly, that's just the workaround. It's a quick fix because I'm going to be doing the thing. So
right. Yes. That's exactly right.
Yeah,
yes. And remember, if you're going to intubate them, you're using this time to get ready to intubate them to create the nightmare of the people saying, hey, it's 75 now.
You're prophylaxing.
Also something to add that I've seen, bag valve masks is know your gear. A lot of people put a bag valve mask to breathe through. You're not pushing the bag. No oxygen comes out of the other end of the bag valve.
Depending upon which kind you have,
depending on what kind you have. So know your gear. Holding a bag valve mask on high flow oxygen extubation is not oxygenated at all sometimes.
Okay, so on reassessment, 10 minutes later, patient's still breathing, 10 to 12 breaths per minute, O2 sat at 100%, blood pressure 95 over 65, heart rate of 130.
Well, it didn't hit the magic number though.
But what was it? What was it here? What was it there? Okay. So what do you have? You have a downward trend, right?
It's got to be 70, right?
So you're anticipating. So again, you're gonna prophylax them against hypotension. Okay. All right. So what do you do next? 1, normal saline 1 liter, wide open. Continue for a target blood pressure greater than or equal to 90. 2, IV 2 liters, wide open. Continue ensure blood pressure greater than 90. IV TKO, keep them dry at present unless systolic blood pressure less than 90, or maintain peripheral perfusion, titrate to vital signs and skin condition.
Okay, so this is a great one for discussion because the point of putting number 2 in is remember, there are reasons not to give too much fluid that aren't just about TBI. Right. There are, if they have, so he has internal bleeding somewhere probably, right? It's not his brain injury that's making him hypotensive, it's something else. So if you can get him just in the right place until you get him to the trauma center or whatever, that's optimal. 2 liters may end up being more than you need to reverse him. And number 4 could probably technically be okay, right? But probably simplicity, staying on focus.
But he's trended down, right? He's gone from 140 to 95. Yeah. Yes.
Absolutely.
So this
is the start, but number 4 may mean that you go to number 2 after you done number 1, or a 3rd liter. So it depends on where you're at.
In this scenario, if you say this is going at 10 minutes, in our system of Phoenix, we like to have patients on the way to the hospital in 10 minutes. So you might want to put 5 minutes or so.
Okay,
that's a good idea.
Yep, that's easy. That's a good point, John.
Okay, your outcomes. If the fluid was given, patient had a complicated course but appears to do well, GCS goes up to 14. Fluids delayed and not given, patient becomes hypotensive, has significant brain damage, a GCS of 10, likely have long-term poor prognosis. So again, this one's really focused on the perfusion issue, maintaining cerebral perfusion.
Can I argue a point about, so my initial assessment of this guy is he's a trauma patient. I'm thinking TBI in the background because I'm here today, but he's a trauma patient. So I'm getting him 2 IVs, I'm giving him 2 bags, I'm running him wide open. So the time that I spend with him fluid-wise am I going to get behind the curve once I drop him off your facility?
Explain what you mean.
Okay, so he's a trauma, so all of my protocols or standing orders, whatever you want to call them, he's going to get 2 large bore IVs, he's going to get 2 bags that are going to run wide open, because I don't know where the holes are in the container at this point. So, as I'm driving to the hospital, those bags are just going to continue to flow as I continue my ALS assessment. But he's a trauma patient to me right now, so he's going to get two large bore IVs with 2 bags flowing.
A couple things. From the perspective of the TBI management, the first leader wide open, since you know he's going to be less than 90 soon, and you're trying to prevent it, the first leader wide open from the TBI perspective is the thing to do, and quickly follow it if he continues to get hypotensive. In most of the trauma protocols, it's hypotension that starts the big IV boluses, not just multi-system trauma, but hypotension. And here's where it's worth having a conversation briefly about the concept of permissive hypotension, right? Which comes to, so the gunshot wound to the abdomen, and the person has a pressure of 90, but you're close to the trauma center. It's probably best to have 2 or 3 large bore IV lines in, but hold right where you are. Because of the whole dilutional issue, and probably many of you have heard about this, and there's quite a bit about this, but that comes from penetrating, in pigs, it comes from actually arterial injuries that you can completely control. In Houston EMS, it was gunshot wounds to the torso, right? But it was never in people with TBI. So what my response personally to that would be, what you want to do is start the first leader and then keep them above 90. But the intent isn't just to pick a big number and just give them a lot of fluid. Unless I'm missing the question, I hope we track.
Once you're going to do your 2 large bore IVs, you can start running them wide open, but we're going to reassess them at some point. And,
absolutely.
And we want to just keep them above 90. So once he's there, you crank those things down. Yeah. And then reassess them again. So you need to wide open them up again. Go ahead.
I think that's where we're going wrong, because you said give him a leader.
Right.
They didn't say give him a little bit and then reassess. And like you said, we just went to that county CD and they're like, don't give fluids, kind of thing. And then,
not for brain injury, they did.
Well, and this is a multi-system trauma. Yeah, that's why he's kind of pointing that direction.
You're not pointing to us why this guy's we understand this guy's probably a traumatic brain injury because he's a car pedestrian. But the thing is that we're treating the multi-systems trauma. This is a pelvic fracture. He's going to bleed out a lot from there. And not only that, we're thinking that if we give this guy too much fluids, the after effect that they were saying is that they third space all that fluid. It's a lot worse condition for him. We don't know how bad his traumatic brain injury is unless we look at his pupils, his disability, anything like that. So it's just, we're trained to give fluids, but now they're saying give him fluids just enough for peripheral pulses, okay, and go from there. We're not thinking brain injury unless there's signs of herniation, there's trismus and everything.
In the setting of TBI, the worst thing for the patient is hypotension. Right. Now, notice, the balance here is, no one is saying treat them to get them back to their normal blood pressure. Nobody is saying try to drive them to a systolic of 130. But the reason why, to stay true to the national guidelines, if a person's gotten, if you think that their blood pressure is 90 because they're, a 13-year-old female who weighs 80 pounds and their blood pressure is always 90, then obviously you don't just go off willy-nilly. But the concept is a person who is multi-system trauma and is getting or is becoming hypotensive or is hypotensive, that you run the first leader in. The reason why that's in the guidelines is there's no evidence whatsoever that one leader in a typical adult with a TBI, that there would be any downside to that. And there's huge evidence that being ginger and letting them stay a little bit low for a while and then finally say, oh, well, we better catch up a bit later, there's good reason to think that's not good for them. So the one leader is a part of the EPIC protocol because that drives right out of the national guidelines.
Yeah, and we're not making this up. This actually is the national guidelines. What you're
It's a great teaching point because
then
when you talk about trauma, that becomes instead of the distracting injury, the bilateral tib-fib fractures, everybody goes, oh, you're now looking at, okay, now let's throw the brain into the process. Let's start talking about the possible problems of secondary injury. I don't think it's contradictory to say we got 2 large bore fluids going in. Now we're just going to give us a number, say, okay, to take care of the body and the brain was like systolic pressure.
Above, you want to be at 90 or above.
Yeah, normal.
one thing that I agree that it's really not contradictory if you look at the patient, regardless of the mechanism and the injury itself, having a systolic at or just above 90 is going to maintain brain perfusion, regardless of what's going on with that patient. It's also going to keep that patient perfused, but not overly so in case they do have an abdominal injury. So using that threshold, if you will, across the board is never a bad thing. If you're going to keep the person perfused and you're going to keep their brain perfused, and then allow the diagnostics to happen later.
Dr. Spade, I just can't stop from saying this. You said several times, and a bunch of people keep using the word 90, 90, 90. This 90 thing is very simplistic, the science behind it.
It is.
The cerebral perfusion pressure thing would suggest that the blood pressure should be normalized or optimized.
Yes.
Not just be happy with 92.
That's correct.
120 would be far better.
That's correct.
Okay.
In an isolated, so this is exactly why we gave why what could be a 1 hour course is a 3 hour course with you guys in the room. The bottom line is, if you know you have isolated TBI, you would much rather have them at 130 over 90. Much rather. But the problem is 80% of American TBIs are multi-system trauma. And so this is the guideline that has taken both of the issues, which is you don't want to drive high blood pressure.
This is the balancing act.
But what everybody knows for sure is TBI is probably going to be the primary predictor of most multi-system trauma. Not all, not every one, but most. And what you know for sure is if you allow them to stay under 90 for more than about 5 to 10 minutes, it almost doesn't matter what else anybody does. They're not going home, and they're not going back to work, and they're not going back to school. They're going someplace else or to the grave. And so, yes, the point is keep them at or above 90, recognizing that if you have an absolutely isolated TBI, it's perfectly reasonable to use your cognitive skills as a healthcare professional to say, oh, no, this person we know somebody saw him get hit with a baseball bat right here, and he's not bleeding anywhere externally, then absolutely, I would say,
so the visceral injury and the brain injury are both important. Probably the visceral injury out-trumps, the brain injury out-trumps the visceral injury, and that's where the 90 is the balance.
Well, maybe if I can clarify going back to that question, the reason I didn't like that question is because you're presenting me with a trauma scenario. So my trauma is, yes, I'm going to give them a liter. It doesn't matter if that comes from one bag or 2 separate bags. If I get 5 from this and 5 from this, still it's a liter.
Absolutely.
It's just that question. I didn't like the way that question
Okay, that's a good point. I get that. And by the way, as you've learned, as strongly as 20 years ago we thought we should keep them dry, the reality is if we err, we probably should keep them wet. Interestingly enough, that may be true in way more than just brain injury from the ICU literature now. But I think your point is a really good one. Right? It's about a total amount of fluid infused.
Right.
Well, and I think that when you drive home, that the fact that the systolic blood pressure's up doesn't matter because your ICP's up. So therefore your CPP is not going to be as high anyway. So you're going to have to drive your blood pressure up. And 90 is not going to matter because we already know they've got enough. If they truly are a head injury, they have an elevated ICP, which of course we can't monitor because we're unseen. So it doesn't matter if they're in the 120s or higher. And I think that's what we need to drive home to them.
Well, if it's multi-system, though, and you get to 120, you're going to break any closets already formed to try to stop that bleeding.
Yeah, that's why, so just so everybody knows, the TBI national guidelines don't drive back to what we would consider a normal blood pressure because the vast majority of TBI patients who are hypotensive or getting hypotensive are not hypotensive because of an isolated brain injury. They're hypotensive because they have multi-system trauma. And in that setting, the threading of the needle today in the literature strongly says keep them above 90, but don't drive them back to normal. And I think everybody understands that balance, and the good news about it is it's quite simple. If the kid makes it to age 10, double figures, everybody from there on up, you don't let them be below 90. That's the take-home message if they might have had a significant brain injury.
I think one other thing you mentioned too, that we're citing a lot of the trauma literature that you guys are hearing from the trauma guys. That literature is not placebo-controlled, well-controlled studies. They're observational studies. They're not great data. There's some flaws in it. They haven't done an epic on penetrating abdominal, multi-system trauma. They're implying this from other data, so we're balancing.
So we're going to stick with the guide. Again, these are great discussions, but all these discussions have gone into developing the guidelines. So everybody's hashed this stuff out. So the main point of scenario number 2 is to reinforce how bad hypotension, I think we've nailed this, and hypovolemia are for TBI. While officially this patient hasn't become hypotensive, at the initial decision point, if they're not treated, they will become hypotensive. So we're prophylaxing against hypotension. Either the official 1 liter or getting started with fluids, of course, depending on your transport interval. If that's short and you don't have time to get a whole liter in, that's acceptable. Generally, the provider should stick with 1 liter if the blood pressure is dropping precipitously like it is in this patient. Okay? All right, so we're going to press on. So we talked about
that.
Okay.
Oh, by the way, this is an important point. This person who, if you follow through and this person gets properly perfused, this guy starts waking up. This ends up being the person who had a long, and you've probably seen some of this, some people have profound loss of consciousness for 2 minutes, and some have it for 20 minutes, and some have it for an hour and a half. And this is a person who looks like they have a terrible primary brain injury, but it turns out that they don't. Okay, so this is a person who had a GCS of 3. You just are still there in the interval because you got there so quickly, where the guy's still unconscious. But this guy with proper management is going to wake up. So we've shown both ends of the spectrum here of pay attention to brain injury. Don't look at the person with the GCS of 3 maybe 8 minutes after the injury when you show up and say, oh, he's gorked, it doesn't matter, because he may in fact not have a profound primary brain injury. And don't look at the person who has a GCS of 15 but did lose consciousness. Don't look at them and say, go to the clinic. So it shows both of those types of patients.
And so again, this point of scenario 2 is really hammer home. It's not perfusion or oxygenation. It's both together. So as far as the airway management and the oxygenation, this patient, they needed to be pre-oxygenated with a non-rebreather at the very start of the assessment. Anything else is suboptimal, and especially true if they're going to intubate or do RSI. Several minutes of pre-oxygenation is critical. Okay, next.
Just one other point. Checking the glucose is something that's simple to do, and it's part of what's recommended for brain patients. And I think that should be part of each of these scenarios as a reminder that we start doing it every time.
It's part of the protocol. It's part of everyone's protocol. We're not saying don't do that at all.
Let's ask them. We've been trying to push simplicity. There's more. If you look at the 4-page protocols, John, for the entire adult protocol and entire youth protocol, they're like 3 or 4 pages. They include discussions of what glucose level and so forth. In this, we've tried to push really hard at the 3 H-bombs for great simplicity, recognizing that the percentage of patients who have TBI and simultaneous profound hypoglycemia is rare, and so forth. But you're the experts in the room.
We're trying to focus on the pillars of what really we think will move the needle, as opposed to...
Are we going to spend our time arguing about whether it should be 60 or 70 or 50?
No, I don't think there'll be an argument.
Okay, just remember.
So just add it in
just
there.
Build it in.
I think it's just a reminder.
Glucose every time it can stress.
It's your normal protocol anyway.
Yes.
And then go on.
Yeah.
We don't have to assign a number.
The only
glucose
Put them all normal glucose.
Yeah. Okay, that's a good point. That's easy to do. Yeah, and that is, of course, again, all of them.
Okay,
It used to be 4 H-bombs, by the way.
It's in the provider manual that you did that
Now
one,
it's
so
3.
it would be easy enough.
The
to go back
hypoglycemia
in.
is just too much to argue about, and it's so rare.